I'd like to extend a warm welcome to Wendy Palmer from Banksia Palliative Care. Wendy has over 30 years experience as a registered nurse and has worked for Banksia for about 5 years. Some of you may know Joanna. She's our PAN support counsellor, and prior to this, she worked in community palliative care, supporting people living with life-limiting illnesses, including those with upper GI cancers. The session today aims to raise awareness of the breadth of palliative care and the supports available to patients and carers. If you have questions throughout the session, we encourage you to use the chat box and Wendy or Joanna will respond to these. Over to you guys.
Thank you. I'll just share the screen. Okay. Can you see the screen? See the slides?
Yep, looks good.
Okay. All right. Yeah. Sorry, we've just got a funny display for ourselves, so we're just going to bring that up. There we go. Okay. All right. Hello and welcome to today's presentation. As Alison said, the presentation today is palliative care. It's more than you think. Now the theme, It's More Than You Think, was taken from the campaign for Palliative Care Week in 2021 to raise awareness of the breadth of palliative care and the types of services available. So as you know, my name's Joanna and I recently joined Pancare Foundation in a counselling role and I'm a social worker. And yes, as Alison said, I previously worked in community palliative care at Banksia with my co-presenter, Wendy Palmer. And yes, Wendy has 30 years experience as a registered nurse and has worked in community palliative care for 5 years. So we thank Wendy and Banksia Palliative Care for being with us for today's presentation. And just to acknowledge that during this presentation, we will touch on end-of-life care. And if you find listening to this difficult, we encourage you to do what you need to do to take care of yourself. And as a reminder, the presentation is being recorded, so you can always come back and watch another time.
Okay. So hello everyone. Thank you for inviting me to join in with this presentation. Like Joanna said, we're talking about palliative care. Banksia, just a little spiel about Banksia, but Banksia itself might not be relevant for you, but we're a non-for-profit organisation and solely government-funded community palliative care service for 3 local government areas of Banyule, Nillumbik and Whittlesea. We provide 24-hour care, palliative care across a population of approximately 420,000 people over a square kilometre of about 1,000. Over the past 30 years, Banksia Palliative Care provided no-cost expertise and practical support to children and adults living with a life-limiting illness and supporting them in their homes, whether it be an aged care facility or in another housing setting, with the aim for decreasing the need for hospital visits and stays, and also just supporting clients' and families' wishes. This week we've hit 400 clients, which is the first time ever. When I first started, we were at about 190. So it is a growing area. So we're quite busy and we're very passionate. All of our staff are very passionate in providing the best possible palliative care.
Okay. So the aim of the session is to answer questions about palliative care, what it is, who it's for, and what it can offer to enable you to better understand the scope of palliative care and the support available to you and your families and carers. And along the way, we hope to bust some myths about palliative care to try and reduce the understandable anxiety that might come up if a health professional suggests getting a palliative care service involved for you or a loved one. And yeah, just as we get started, I just wanted to draw your attention to two websites that provide information about palliative care in additional community languages and tailored resources for families, health professionals and clinical services to support the provision of palliative care at home for Aboriginal and Torres Strait Islander people. So these two websites are moreyoucanthink.org.au and caringathomeproject.com.au, and we'll put the links to those websites in the chat function.
Oh, sorry.
Okay. All right, so we'll start with the definition of palliative care. So up on this slide, I've put two definitions, one from the World Health Organization. So they say that palliative care is an approach that improves the quality of life of patients, adults and children, and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment and treatment of pain and other problems, whether physical, psychosocial or spiritual. And Palliative Care Victoria's definition is palliative care is a person and family-centred care provided for a person with a life-limiting illness for whom the primary goal is to optimise the quality of life. Palliative care is care that helps people live their life as fully and as comfortably as possible when living with a life-limiting or terminal illness. Palliative care identifies and treats symptoms which may be physical, emotional, spiritual or social. And palliative care is a family-centred model of care, meaning that family and carers can receive practical and emotional support. So from these two definitions, we can see the commonalities, the focus on quality of life. It's a service for patients with life-limiting illness and their families, and with the aim of treating physical, emotional, spiritual and social symptoms. A very brief history of palliative care. So up on the screen is a picture of Dame Cicely Saunders. She trained as a nurse, a medical social worker, and finally as a doctor, and began caring for people with a terminal illness in 1948. So she recognised that the inadequacy of the care of the dying that was offered in hospitals and founded St Christopher's Hospice in London in 1967. She believed in the importance of providing holistic care, combining excellent medical and nursing care along with the emotional, practical and spiritual support. And she also saw the patient along with the family as the unit of care. In 1969, Dame Cicely started the first home care team, so taking the philosophy and care of St Christopher's out into the community. And one of Dame Cicely's most well-known quotes is shown on the slide. "You matter because you are you, and you matter to the end of your life." And a Canadian cancer surgeon, Dr. Balfour Mount, visited St Christopher's Hospice and began a similar service at Montreal's Royal Victoria Hospital in 1974. Dr. Mount coined the term palliative care. Palliate comes from a Latin word for cloak, the intent being to protect those living with a terminal illness with attention to quality of life.
So we're just going to look at who is palliative care for. Palliative care is for people of any age who've been told that they have a serious or a life-limiting illness that cannot be cured. It assists people and their carers to manage symptoms and improve the best quality of life. And it's beneficial from the time of diagnosis with a life-limiting illness and can be given alongside treatments by other doctors and specialists. So people are often referred to palliative care either by a GP or a specialist treating team, aged care facility. Often we get a lot of referrals, and a hospital palliative care team make a referral upon discharge from hospital. Clients and carers can also self-refer. So sometimes we get referrals just from the client themselves or their family or loved ones, just because their medical team haven't done it, or it falls by the wayside, which does happen, unfortunately. So anyone can refer. So one of the myths of palliative care is, and it's a very common one, is that palliative care is the end-of-life care. A lot of people think it's just right at that last end, but it's actually not. It's we like to call it more quality of life care. Some people they think it is that end of life, and however, but we can help throughout all stages. And sometimes we have clients with us for several years. So it doesn't mean, giving up hope. It's about managing symptoms as they occur and living as best as comfortably as possible. Some studies have shown that if palliative care is seen early and symptoms are controlled, people will live better and actually may live longer because their symptoms are well controlled, and they're also emotionally more not stable but comfortable. So yeah, like I said, there's many. Sometimes we do see clients for many years, and some clients we do get discharges from because they're no longer needing palliative care. Not that they're cured, but they get discharged from our service, and then they can refer anytime as required.
So who's in the palliative care team? So these are the health professionals who provide palliative care. So there may be differences between palliative care services. So, for example, some community palliative care services may not employ an occupational therapist and instead refer to community provider for OT assessments. And some rural and remote areas may have reduced resources and therefore have limited access to, say, massage or music therapists and volunteers. But generally, the team is of nurses, social workers, bereavement counsellors, palliative care physicians, and occupational therapists, music therapists, massage therapists, and volunteers. And palliative care, where is it provided? Well, it's provided where the person and their family wants to be, or where possible. So this includes at home from a community palliative care service such as Banksia Palliative Care, in hospital, in a palliative care ward or an acute ward by the Pancare consult team, in a hospice, and also in residential aged care as well. If that's people's homes, that's where we go.
So another myth is that going into palliative care unit is always a one-way trip. So that's not necessarily the case. Need to click.
Yeah, there's extra.
This one?
Yeah.
Oh, there it is. So reasons for admission to a hospice or a palliative care unit can include symptom management, respite, discharge planning, and end-of-life care if that is required. Sometimes clients are experiencing symptoms that become unstable, and we might refer or suggest a palliative care unit bed just to get those symptoms under control. And our service can make a direct referral to the inpatient palliative care unit, depending on bed availability, which would mean hopefully avoiding a presentation to the emergency department. So, for example, we might someone might be having unstable pain, what we might consider a pain crisis. That's just an example, and we could ring, for example, from where we are, we would ring the local hospital here, the palliative care unit, and find out if they've got any beds available, pop a referral in, and the bed may not be available for another 24 hours, or they could have a bed available, and then we would arrange hospital transfer, a non-urgent ambulance to to that palliative care unit rather than going to the emergency department. And then once the symptoms are stable with an updated symptom management regime, the client can be discharged home with our ongoing support and maybe a new medication regime, for example. So that's our inpatient local palliative care units are often used for that reason. And also some clients go in for respite to allow the carer to break from the caring role. And then the community palliative care service can try and arrange that as well, along with more supports in the home for when they do come home, because things change. So when a client's preference is not to die at home, for example, or if circumstances and their condition prevent them to be managed at home, then they can be admitted to the palliative care unit. There is no right or wrong. Everyone's circumstance is unique, and people don't need to make these decisions straight away, or they don't need to know the answer to that choice. It's just these things can happen as particular situations arise. So what support is provided? We provide this type of support for pain relief and other symptoms, for example, vomiting and shortness of breath. This is a very brief list overview of what support we provide. It ranges from symptom management to hiring of equipment and practical and emotional support, along with advanced care planning and grief and bereavement support. So our occupational therapists, which we do have, but not all palliative care services do have an occupational therapist. We may arrange equipment for in the home. We do have a carers support group, and there's also a walking group that catch up as well. We have the social workers, which assist with planning for future medical treatment decisions and goals of care. And we do assist with linking in with other services such as home help, My Aged Care, NDIS, and financial support. We do get some donations which are often, well, they're always go back to the client group. Sometimes we offer financial support in the way of paying for bills and other equipment that may be required when finance is an issue. And also support people to meet cultural obligations and emotional and social and spiritual concerns. Counselling and grief support, and along with referrals to respite care services. So our community palliative care, the medical and nursing teams, again, we provide the symptom management. We have our own team of palliative care physicians who specialise in palliative medicine. Our visiting nurse will refer a client to our palliative care physician when an issue is identified, or our palliative care physician will visit the client at their home, if able, the client can come to our clinic. We have a little clinic here in our room at our office. And once reviewed, the issues identified with a plan in place, and the doctors communicate and work alongside with the client's GP and the community palliative care team for the best outcomes. We always go to the GP for first port of call, because they do keep writing the repeat scripts but the palliative care physician can make suggestions in changes and also provide scripts for particular medications depending on what they are. But we do work together very closely with a GP. So those, the other things that the medical and nursing team provide assistance with is coordinating the client's GP and specialist doctors. We provide education and bed-based care for clients and their carers, including terminal care support. We attend home visits as required. So some people we might see once a month, others we might see every day. We assist with advice for nutrition and fluid intake, assist with hygiene and personal care and provide education with that. Pressure area care, mouth care, eye care, continence care, all these things that come about when people are requiring care at home. Sometimes we assist with providing that personal hygiene for someone who is bedbound, but also provide education in regarding to clients who need that. If sometimes clients ask us if we give like IV fluids in the home or IV medications. If that is required, then a hospital transfer is generally required. We don't provide that in the home. So another myth for palliative care is the opioids, that opioid medications hasten death and opioids are addictive. So some people fear that these are being prescribed. When these are prescribed, that means, oh, they're heading towards the end of life. And that is a known myth. Some nurses have said, oh, well, as soon as they're on morphine, that's it. They're at the end, but it's actually not the case. Relieving clients' pain, making them comfortable is improving their quality of life. Opioids can be addictive in certain situations, but it's not. There's never been an issue in palliative care. When someone is requiring a bit more opioid medication, it's generally because of tolerance that can develop and due to progression of illness, which is monitored very closely by your palliative care team. Here's just a little video on common fears that people have about morphine.
Yeah.
Sorry, we don't have any audio, Joanna.
Okay. I wasn't sure if that would be the case.
We can include it on our follow-up email or in the chat, the link.
Yes, possibly if we pop the we'll pop the link in the chat so people can watch that at their own time. It's fun. I click on it.
Well, that's a shame.
No.
Okay, we'll just
sorry about that. Sorry about that.
Sorry. It's the IT that it works when you try, but then it works on the day, it doesn't. Yeah. So Opioid analgesia, and this, we're not covering this in great detail, but it is just some of the fears that does prevent people from using opioids for symptom management. Opioid analgesics are defined as drugs that have a morphine-like effect. Is commonly used for controlling pain in palliative care clients. It is the gold standard for cancer pain relief. It's predictable. The dose can be adjusted quite precisely, and it is the first choice because it's been around for so long and we know how it works. Availability and cost is preferable to other analgesics, and it is superior to other opioids. Some opioids are quite strong and we tend to go to them at second or third line.
All right, so just to talk a little bit about the social work team in community palliative care. So social workers are skilled professionals who can assist people to address personal difficulties and structural barriers in their lives, as well as provide advocacy on behalf of people experiencing distress. So clients in community palliative care are allocated a social worker who will assist with a variety of practical and emotional issues. So this could include counselling, making referrals for extra help in the home if needed, or referrals for in-home respite to give carers some time away for their own appointments or other needs. So in my experience, you know, it's not uncommon for the social worker to just be supporting the carer in their caring role, and rather than working directly with the patient. Sometimes the patient doesn't feel that they have any need for social work input, but the carer would like that, and that's absolutely not uncommon. You know, where palliative care is person and family centred, so we meet people where they are and provide support as guided by them. So social workers can also provide assistance with reducing financial burdens or stresses, try and assist navigating Centrelink as much as we can. I'll put the caveat there. And also social workers can liaise with workplaces and schools. As we mentioned earlier, organisations such as My Aged Care. And social workers are also able to talk through the benefits of advanced care planning, to provide information about assigning someone as a power of attorney or medical treatment decision maker. Those terms might vary across states, so I apologise, this is a bit focused on Victoria because this is where we're based. Yeah, social workers can definitely assist with thinking about advanced care planning, and including in that is also the consideration about completing an advanced care directive, which involves documenting your preferences for your care, including medical treatments that you do and don't consent to. And it can include your values, life goals, and preferred outcomes, and speaks for you if you no longer have decision-making capacity. So, yeah, social workers can just, facilitate conversations around that if appropriate. And the community palliative care team also includes grief and bereavement counsellors who can provide grief counselling and support, facilitate bereavement groups, and support for the entire family as required. And sometimes the grief and bereavement counsellors will meet pre-death as well. There's a lot of loss, obviously, associated with living with a life-limiting illness, and anticipatory grief as well. So the grief and bereavement counsellors are there for as long as needed. Banksia support for 13 months following the death of a loved one. That might vary across services. Other members of the team, the music therapy team. So music therapy has been researched and shown to have many benefits in the palliative care setting. These include alleviating pain and promoting physical comfort, achieving feelings of relaxation and peace, management of anxiety and mood, positive engagement opportunities for families. So, playing music together, facilitating that, and improve quality of life, emotional well-being through difficult times. Also the provision of legacies, so, creating music with the patient, and coping mechanisms to assist with grief and loss. So our music therapists, do support that can be particularly beneficial for children as well, in the grief space. That's definitely something that our music therapist is often involved in, supporting children. And it's important to say that to benefit from music therapy, a person doesn't need to have a musical background or musical talent. You don't need to play an instrument to see the benefit of music therapy.
Another aspect of community palliative care that Banksia offers. Now, am aware that in rural areas, not all palliative care services will have music, massage and occupational therapy. Sometimes it's a bit of a nice to have. So massage is also really important. It is shown to provide pain relief as well as relaxation. The oncology massage therapists have extra qualifications to provide this service. There's extra studies that they need to do because it is quite different to just normal massage. And it's quite nurturing and does encourage relaxation. It's collaborative and tailored to each person's individual needs, and the clients, massage for the clients as well. So it's the clients and their families really love it. And again, like mentioning with the occupational therapist team, they assist in care education for manual handling techniques and transfers and mobility. They assist with, managing symptoms by providing education and also equipment to make life a bit easier at home. They can assist with completing the NDIS applications for equipment, although that is quite timely at the moment, and great big long waiting lists, which is probably similar to my aged care as well. So we try to do our best to assist with equipment in that regard, and sometimes some of our donation funding goes towards equipment for families, because the wait time for some of this through other avenues is too long. So, our OTs may suggest a wheelchair. We can arrange a shower chair or a stool just so you can decrease that risk of falling. And it's more just because of fatigue from treatment, for example. There are over the toilet seats, commodes, hospital beds as required. So again, that contributes to the best outcomes for the client to live their best active and comfortable quality of life.
Okay, and then we've got the volunteer team as well. So for community palliative care services who are able to engage volunteers, they visit clients in their home to provide companionship and social interaction. The volunteer coordinator will aim to match people on their interests, so both are comfortable with the relationship. And in collaboration with the social work team, the volunteer team arrange and attend carer meetings. So Banksia have a carer circle and also carer walks that the volunteers participate in. And they can they sometimes assist to produce a memoir photo book or a biography service. Yeah. So putting together a biography, the story of important things in a client's life that they'd like to share with their family.
One of the clients recently, she spent a lot of time going through all their old photos and putting this memoir book together, and it turned out fantastic. And, you know, for us that are in the age of photo books, you know, the good old days of the hard copies. So that was therapeutic in itself for her and her family to go through all the years of photos, along with the digital ones as well, the more recent ones, and put a book together, and she loves it. She just loves it. She keeps going through it with her family. Yeah.
Okay, so these are just some other resources for people to explore further if it's of interest to you. So the Live the Life You Please campaign is a film-led social impact campaign, aims to improve awareness about palliative care and advocate for increased access to palliative care, and aims to help start conversations about living the life you please until the very end. There's a TED Talk there linked to a TED Talk with Dr. Catherine Mannix, Why We Don't Talk About Dying, which is very interesting if that's something you'd like to look into. And also for more information about advanced care planning, the advancedcareplanning.org.au website is the one to go to, and we'll pop those links in the chat as well.
So with just regards to referring to a community palliative care service, like I said earlier on, anyone can refer themselves, really, a loved one or a friend. Sometimes we get a neighbour calling and then we say, well, we really need to talk to, you know, some other people about that. But to make sure that they've got permission. So GPs, nurses and other specialists can refer. Once someone refers, we do end up calling a GP or a specialist for just to get some more information, and that would be medical information. The best way to refer is via our website. There's a link there, and just halfway down the page there's a button for how to refer. And if you're out of Banksia's catchment area, if you go to Palliative Care Australia, they have links for different states, and then those states will have their own different palliative care services that cover your particular area. So for the north where we are, we cover at the northern suburbs up here, whereas, say, for example, the eastern suburbs would go to Eastern Palliative Care Service. So that's all there on the palliative care website. It goes to the National Palliative Care Service Directory.
Okay, there's some references. Yep, a couple of references and a couple of pages of references. Oops, what's going on? And now time for questions. So I'll just stop sharing so we can see. Stop sharing. There we go. So, does anyone have any questions? Feel free to unmute yourself and ask any questions. If there's anything we didn't cover.
So does anyone want any clarification?
Yeah, so some examples from tech chat.
I don't have any questions at the moment, but there's some useful information there, so thank you very much for that. Some of that I will follow up.
Okay.
Good.
Okay. Yeah, I think the knowledge sharing session one will help, because that was a very clear example of when we prepared a presentation and delivered it. So
that was a great
presentation.
Sorry, so someone else talking. I can't.
Yeah, where's that talking coming from? I thought it was a question.
Oh, I just open up the chat. So, question: if I'm in a community palliative care that doesn't offer massage therapy, can I get a massage at a local massage place, or the Pancare team know where to send me?
So there are actually.
Yes, I can put in this one.
Oh.
So I've got
Yeah, that's good.
There are some, we find that there are some oncology palliative care massage therapists online, so you can contact them that way. You wouldn't go to just a normal, your local massage place. I would look up oncology massage because it is a specialist area. And there are actually quite a few people that run a private practice. Having said that, you would have to pay for it too.
Yeah, I think there is oncology massage Australia, I think.
Yeah.
We'll have a link. We'll have a list of qualified oncology massages. I'll just see if I can.
There are quite a few around.
Yeah.
There are a few around, but it does. And this is where there would be a cost. I couldn't tell you what the cost is. Usually they're quite reasonable because of the nature of the massage, and so they are out there. But you're absolutely correct, because not all palliative care services offer massage. We're lucky. There was another question there. In our resources, shower chair or commode from a local op shop. Yes, I see them there all the time. Absolutely. Look, we often get ones donated as well, and just the only practical thing really is you've got to check to see if they're going to fit in your particular shower. Some of them are a bit big, depends on your shower. Some people's bathrooms are small. Yeah, if that works for you, and it's, make sure that it's stable and it's safe, that it's not breaking. Yes, you can, but it's not OT, it's not approved by an occupational therapist, but definitely you can if it fits and it's safe and it's not damaged. Yep.
Oh, very good question. Does palliative care service cost me anything? Yes, that's a good question.
It is a good question. No, so our community palliative care, there is no cost. You're not paying an hourly rate, for visits or anything like that. There would be costs associated with, say, for example, if we do hire a bed, there might be a delivery fee we use Able Living mostly, but there are other services out there, so there might be a $20 or $30 delivery fee. That includes delivery and pickup, I think. I'm just trying to think what else. It is a free service.
Yeah, government funded.
It's government funded. Just trying to think what else you would be out of pocket for. Just medication, really. No, I can't think of anything else, to be honest. That the 24-hour care is that after hours and weekends, it's mostly telephone support. But then if, there's an urgent situation required, we have nurses that are covered on call. So from 6:30 at night to 6:30 in the morning, we have nurses scheduled to cover on call for just in case there's, I'll just give an example of uncontrolled vomiting or something, and you need subcutaneous injection to help with that if that medication is in the home. We don't carry medication with us. That is all in the home, and we try to preempt that kind of medication as things progress. Does that make sense?
That answers that question. Yeah, if you wake at 3 in the morning in pain and I can't get it under control, can I call Pancare team instead of an ambulance?
Yes. So. Yeah. So if you've got the medication in the home, so that's one of the points. So when people get to a particular point in their condition, then we say, oh, look, maybe we should have some of these injectable medications in the home, and they may never be used. It is for just in case. And we have the orders and everything's in place for the nursing staff as well. And then definitely you would call that 24-hour service, which we would give you all those details. And then they would call us, for example. I'm on call this weekend, Friday night, Saturday night and Sunday night. So between 6:30 in the evening and 6:30 in the morning on those nights, I'll have the phone next to me waiting for a call. I may not get called, but sometimes you do. And we definitely had one of our nurses go out at 3 o'clock in the morning, not yesterday, but the day before, to assist with that. So if it happens, it happens, but it certainly does avoid those hospital visits. We try to avoid them. They're not always avoidable. It depends on the circumstance, but yeah, definitely. We do our best. Is that helpful?
Just wanted to say something. Firstly, thank you so much, both of you. That was a great, presentation, very informative, lots of useful information, and I'm sure that recording will pass that on to lots of our patients and their families. So one of the things, Wendy, that I find in the conversations I have is quite often individuals don't know about the palliative care teams and whether they have access to any. Secondly, how to go about getting referrals to them. So have you faced that as well when people eventually find you? You mentioned that you can get referrals from anywhere, from GP to the oncologist, but where typically would be ideal for you? I know at the diagnosis stage would be really ideal, but a lot of people that I speak to don't seem to know about these services. And it's a real shame because there's such a breadth of support that you give.
Yes. And we do like to see people sooner rather than later. But understandably, we also get a fair bit of resistance to, even if we do get a referral and we ring the person or the family, and we bluntly get, I'm just going to, I'm not there yet. We don't want you. And that's okay, because we're not going to force ourselves onto anyone. But we get most referrals from hospitals, from the local hospitals here, but also from GPs. Yeah, I guess it is one of those things that people don't know that is available, that it's there, even especially for as people age, as they're getting to the end of their life, there's not necessarily a cancer diagnosis. They don't realise that they can get that support at home. We're actually trying to put ourselves out there a bit more, but people are a bit frightened too. So they don't, understandably, they don't want to hear it. And that, of course, so that's, I guess, earlier on in the piece, many years ago, palliative was that last few days or weeks. So it's not like that now. We like years quality of life.
Yeah.
Does that understand?
Yeah, it does. I just wish, it was sort of mentioned at the, at a doctor's appointment or at the initial stages of conversation, just to say it's more supportive care, as you mentioned, quality of life, whilst you're going through it. So it's, I've certainly found in many conversations I've had that once that contact is made, there's so much relief and there's so much gratitude in having a social worker reach out and, especially caring for the members of the family, not just the patient. So
yeah, it is. And we are caring for the family, sometimes more so. Yeah. It is to support the family. It's not, really, it is probably more that as well. And it supports them with just reassurance at that phone call. Oh, I need to give such and such this medication. Is it okay if I give them this? And it's that backup conversation to give them reassurance that, you know, they think that they're doing them harm when actually they're not. But it's just another voice. It's a person on the other end of the phone. We don't necessarily have to visit. It is supporting the family. Assisting them through that whole process. And it doesn't matter what age, because we cover all ages. So it's very important, and we try to explain that in our visits and our initial phone call when we get a referral, like at the intake, because I work at intake too. So we try to explain that in that first initial contact. We're here to support the whole family, all the carers, yourself and the carers. Yeah.
And you mentioned sort of the walk-in support and groups. Is this something that you hold quite regularly?
So it's just a newish thing. Did you go on one of the walks?
No. The other social workers ran a bereavement walk-in group.
Yeah,
with volunteers.
Yeah. So they meet up. We have a carers circle, and then sometimes as that carers circle get to know each other, there's a walk that's arranged. I have to find out how often they run it, but it does depend on how many people are interested. And it is just a handful of people, because out of 400 clients, we get a lot of carers. But not everyone is interested in having that social contact, and that's fine too, but it's offered. So they do a local walk, one of the gorges here, or a park, or a catch-up coffee,
Finish with coffee.
Yeah, finish with coffee. And that's been really helpful. And then some people who continue on, because we have that bereavement support for 13 months afterwards. And when that 13 months is coming to that end, a lot of them continue contact afterwards. We don't say, oh, that's 13 months, we're done. You're like, we don't do that either. Like, obviously, if the need is there, it's just that recommendation, 13 months, because you have the firsts of anniversaries, and it's a recommendation. We have a remembrance service tonight at one of the local halls at the school, so that we're offering that. We do that 4 times a year, and then there's one at the end of the year. So we've got one tonight, and we have about 70 carers coming to that tonight, and then our staff will be, we've got that arranged here just across the road. So that'll be nice. It is nice. They do appreciate it, and it's actually nice for the carers, because we visit everyone in their home, but then we get to see them afterwards. It's really it's nice for us too, actually. I enjoy going. Yeah.
Wonderful. Thank you.
That's okay.
Shannon, you're on mute.
Oh, she wasn't talking to us.
Okay, well, if there are no other questions, then
any comments? You can always call us for advice. Obviously, you're in our catchment. There are other catchments, but do have a look at the website, the local websites, of your palliative care services.
Yeah.
Thanks, Alison.
Yeah, just one other comment is my mum was in aged care and passed away last year, and it was really her last days I started talking about palliative care, and it really was assisted dying. And morphine was
anything else?
The impression I had was that was helping the process along. So yeah, that's certainly a real perception.
It is. It is a real perception. And we go into a lot of aged care facilities every day, and we try to see people well before that last few days. That's what we try to. We're doing a lot of education at the moment regarding into aged care facilities about recognising the deterioration stage quite like earlier than we're getting the referrals, and sometimes people that in aged care facilities are with us for 24 hours. That's, you know, it's such a late referral that, and we do assist staff in the aged care facilities in giving them confidence in how to manage those symptoms rather than family feeling like it's assisted dying, because we try to support the families in that regard too. Yeah, it's a shame that you, I guess you probably feel it was like that. And look, it depends. Everyone's situation is different. Yeah, it's very tricky, and we try to get involved much sooner than the last few days. So there is fear among some staff about even providing morphine and pain relief. So there are a lot of different factors. So I hope, David, that she was peaceful.
Yeah.
Thanks, Wendy. That's okay. Is there any other comments at all? I love the bird on your shoulder, Joanna.
I was just going to say that I was just talking really a beautiful distraction to see.
Yeah, I love it. It's nibbling on your ear.
Yeah.
I think that means it's lunchtime.
Yeah.
Beautiful.
Thank you, Wendy and Joanna. That was very informative. And if anyone thinks of anything else that they'd like to ask, you can email us after the session and we'd be happy to follow up with you.